Hey everybody, thanks so much for joining us for our March Facebook Live session, Colorectal Cancer, No Ifs, Ands, or Buts. My name is Stephen Estrada and I'm a stage 4 colorectal cancer survivor who was diagnosed at the age of 28. I was fortunate enough to land here at the University of Colorado Hospital where I enrolled in an immunotherapy clinical trial that saved my life. Last month, I celebrated 1 year of being cancer-free. Joining me today is Dr. Chris Liu, gastrointestinal oncologist and Deputy Associate Director for Clinical Research at the University of Colorado Cancer Center. It's quite the mouthful. Thank you so much for being with us today.
Well, thanks for having me.
I've known Dr. Liu for about 3 years. We met right when I started my trial, and I think that who I was back then is vastly different than who I am today.
Yeah, it's been unbelievable to kind of see you over the last couple of years and to see how treatment has affected your life. And I'm so proud and amazed that you're here and doing so well.
Well, I'm glad to be a part of this family. So we'll just kind of jump right in. Before I start, I want to remind everyone that we are live, so if you have any questions, please feel free to leave them in the comment section, and we're going to try to get to them. If we can't get to them during this session, we will circle back around and get those answers to you. Let's start with the basics. What is colorectal cancer?
Yeah, so great question to start off with. So colorectal cancer is essentially any abnormal growth that begins in the colon or the rectum, and that abnormal growth over time can obviously lead to a mass, but that can also lead to cancer being spread to other parts of the body. And so colorectal cancer is essentially uncontrolled growth of some of the cells that originate from the colon and the rectum.
And do we know what some of the most common causes of colorectal cancer are?
Yeah, so this is a very common question. A lot of people want to know, well, what is it that causes colorectal cancer? And there really isn't just one cause of really any cancer, and that goes for colorectal cancer as well. We certainly know that there are risk factors for developing colorectal cancer. So there are hereditary syndromes, so genes that are passed down across multiple generations within the family that can predispose you to develop colorectal cancer. And so there's some hereditary syndromes. One of the most common ones that we talk about is Lynch syndrome. So there are some hereditary syndromes that predispose you to develop colorectal cancer. There are other risk factors that we know are common to a lot of cancers. So smoking. Smoking is a carcinogen. It can cause numerous cancers, but colorectal cancer is one of them. We know that heavy alcohol use is also something that can create a lot of inflammation in the body and can also be a risk factor for colon cancer. And we also know that diets that are heavy in red meats and processed foods can also increase your risk for colorectal cancer. And so it's probably a combination of a lot of events. A lot of mutations have to happen in cells over a period of time that can then eventually develop into a colon polyp. A colon polyp is essentially kind of a pre-cancer. And when that polyp continues to grow over time, it can develop into a full-blown colorectal cancer. One of the reasons why I bring this up is because polyps are precancerous and can be seen by colonoscopy, which is a screening modality, obviously for colorectal cancer along with other GI diseases. And within a colonoscopy, you can actually take these polyps out, which means that you have the ability to largely prevent colorectal cancer with good screening.
So we know that guidelines are saying that after the age of 50 you need to start getting colonoscopies, but I think what we're learning more and more is that people under the age of 50 are being denied colonoscopies because of those guidelines. So what do you say to these people who are presenting symptoms who are under 50 and need a colonoscopy but they're not being taken seriously?
Right, and so what we do know is that the incidence of colorectal cancer in the older population is decreasing. It's actually decreasing quite rapidly, which is really, really exciting news. But to your point, we also know that colon cancer or colorectal cancer in younger adults is increasing. In fact, even in the state of Colorado, and we know that this is true not only in the United States but also around the world, that the incidence in younger patients has increased really over the last 15 years, and nobody really knows why. And so the guidelines do state, in the absence of any other genetic or hereditary syndrome or strong family history of colorectal cancer, we should start screening at the age of 50. And those are what the guidelines state. What all of our young patients who have developed colorectal cancer will tell you is that they've been told, I'm too young to have developed this cancer. And so one of the things that I always tell our patients is be your best advocate. You know your body better than anybody. And if you know that something is really wrong, then it's okay to ask questions and it's okay to push. Okay. Some of the most common symptoms for developing colorectal cancer: unexplained weight loss, seeing blood in your stools, having abdominal pain. These are kind of vague symptoms, but they're ones that are associated with colorectal cancer. We just want you to go to your primary care provider and say, I have these symptoms. Do you think a colonoscopy it would be something that would be good for me, or something that could help me diagnose what's going on? And if you find yourself getting blocked from getting a test that you feel like you really need, then it is okay to push, and it is okay to get a second opinion.
And to that point, I would like to say that I was misdiagnosed several times before my stage 4 diagnosis. And what I tell patients a lot now is, you're going to get a lot of no's, but someone out there is going to give you a yes. And you just have to keep going. Abnormal pain, change in your bowels, like you said, weight loss, none of that is normal. And if you're experiencing these, you really need to bring it up to your doctor and be your own best advocate.
Yeah, I will tell you that a lot of the young patients that we treat in our clinics look exactly like you. You're young, you're healthy, you're fit, you really have no other medical problems whatsoever, and so you would be kind of the perfect example of somebody who should never get cancer, especially when they're young. But this is what we're seeing, and so some of this is also education for our primary care providers to say, we just want you to think about it. Again, most of the time, a majority of the time, you're not going to have colorectal cancer. But as long as you're continuously thinking, okay, well, this is potentially a diagnosis that I should be thinking about, then it'll be much, much harder to miss.
So we all know that in order to treat cancer, you usually do a combination of chemo, radiation, surgery. But I feel like we're in a time now where things are moving at light speed as far as new treatments. What are some of the most exciting new treatments that you can tell us about?
Yeah, you're absolutely right. This is the fastest moving field in medicine, with breakthroughs happening literally seemingly every week. One of the things that we know can improve patient care, and this is really, really simple, is having doctors that work together as a team. So we want all of our patients to be seen by a multidisciplinary team. What does that mean? Well, that means your medical oncologist, much like myself, with your radiation oncologist and your surgeon, all working together with a pathologist and a radiologist and a nutritionist and a social worker, all working together as a team for our patients. That alone, with having a team on your side, that will improve not only the way your cancer is being treated and your survival, but also how you're doing and how you're feeling. Those things are also extremely critical. Surgery, chemotherapy, radiation are still the mainstays for a lot of treatment for colorectal cancer. One of the treatments that you're very familiar with that has seemed to make a big difference in a lot of different cancers is this concept of immune therapy. Can we teach or show your body's own immune system to be able to recognize and fight the cancer? And now there are drugs being developed and have been developed that can stimulate the immune system to recognize and fight the cancer for you. And for patients with metastatic colorectal cancer, we know that immunotherapy will be effective for a minority of patients, about 4% of patients. But having said that, we're developing more and more clinical trials, more and more therapeutics designed to try and teach the immune system to be able to find and recognize the cancer. And that's one of the big breakthroughs literally over the last 5 years in cancer medicine.
So I like that you said over the last 5 years, because one of our patients actually sent a question in, and they were wondering, we all know that maybe 10 years ago, stage 4 colorectal cancer was not very survivable. But what do you see happening in the next 5 years?
Yeah, so the sky is really the limit. I think that if you had looked even 5 to 10 years ago and said this is where we would be in 2018, I think we would be pretty amazed. What I see going forward is potentially the development of a combination treatment where we may target the cancer with a targeted drug, something that tries to target what makes the cancer unique from normal cells. And you're going to see those paired with immune-based treatments. And not just immune-based treatments that stimulate the immune system, maybe immune treatments that can teach the immune system, this is where the cancer is, this is what makes the cancer different. Can we target immune cells against the cancer? Can we use a targeted cancer vaccine? And what you're going to see over the next 5 years are results from clinical trials that have tried to pair an immune stimulant with a vaccine therapy, or an immune stimulant with a targeted therapy, or maybe a new class of immune-based treatments where they try to bring the tumor and the immune cells together to try and get the immune system to recognize and fight the cancer. These are the trials that are going to be reported out over the next couple of years, and they represent kind of the next step in the evolution of treatment for metastatic cancer. And the idea kind of being, if we get something that works in stage 4 cancer, then we're going to try it in stage 3 cancer and stage 2 cancer. But the other thing that is really interesting about the future of colorectal cancer is that we're no longer talking about the next chemotherapy, right? We're not talking about the next like mustard gas or nitrogen mustard or anything like this. We're talking about drugs that really are trying to treat the cancer while sparing your normal healthy cells. And so what does that mean? That means potentially providing a treatment that has much, much, much less toxicity, but even greater effectiveness. And that's what we really want. And that's where cancer medicine has really been moving, particularly over the last decade.
Wow, and that's really, really exciting to hear. I know we're going to be using some terms here that some of you watching may not know, so if you need any clarification, please feel free to ask in the comments or join us in Blue Hope Nation, a colorectal cancer support group, and I'd be more than happy to go over some of these terms with you. With that said, 95, 96% of the colorectal cancer patients are what we call MSS, or microsatellite stable. We also know that immunotherapy as a mono agent doesn't really work for them. So what do you see as far as immunotherapy combined with targeted agents or chemos? What's exciting right now? Are there any clinical trials that really stand out?
So there are a couple clinical trials that we're still waiting on results on, and one is the immune-based therapy that you were talking about together with a targeted pill. And so a trial was run kind of combining those two things to see if they would work for patients that have microsatellite stable colorectal cancer. Just like Stephen said, this is 95% of our patient population with metastatic colorectal cancer. We're still waiting on the results of that trial. I think the newest exciting thing for microsatellite stable colorectal cancer are these drugs that it's actually an antibody. And these antibodies have two arms. And one arm kind of latches onto the tumor, the other arm latches onto the immune system. And these drugs are basically forcing the immune system, the immune cells, and the tumor together. And the idea kind of being, well, if you put these two things together, that maybe there'll be some interaction there. And the interaction that we want is for the immune system to kill the cancer. Those drugs are just now starting to be tested in clinical trials. The results are still early, but some have been somewhat promising, and so I think that you'll see more and more drugs like this coming through in the future.
That's great. Besides immunotherapy, because we all know that train's coming, there's been a lot of success, or some success, with the BRAF mutations and their trials. I've heard some patients being told that if they harbor the BRAF mutation, they need to be in some type of clinical trial at this point. So what other biomarkers are we having progress with outside of PD-L1 therapies for MSS?
Yeah. That's a great question. And so there's certain mutations that we know that we look for to help guide treatment for colorectal cancer. KRAS or NRAS are genes that we use even now to actually not give certain medicines, because we know if you have a certain mutation, you're not going to derive any benefit from one of the FDA-approved treatments for colorectal cancer. So what the other mutation that you talked about, BRAF, is present in about 10%, 5 to 10% of patients with colorectal cancer. There's a new promising trial which reported out last year some early results that were really, really promising. Again, it's a small percentage of patients, but there's a really exciting trial for those patients because their prognosis is not as good as patients with BRAF wild type or not mutated colorectal cancer. So that's definitely something that's coming down the pipeline, and we'll get results from that trial hopefully in a couple of months to a year. But to your point, that is a mutation that we think that we may be able to accurately target. Another mutation or amplification of a gene is one called HER2, H-E-R-2. HER2 is a gene that's talked about a lot in breast cancer. We know in about 5% of patients with colorectal cancer that there's amplification of this gene. If there's amplification of this gene, the tumor is then kind of dependent on this gene to continue its growth. Well, can we provide a series of treatments or a combination of treatments to target HER2? And so there's a nationwide trial ongoing now for HER2 amplified colorectal cancer. And so you just have to get your tumor tested. And so it's okay to talk to your doctor about testing for these biomarkers, KRAS, NRAS, BRAF, HER2. It's kind of alphabet soup. But for having said that, just talk to your doctor about it. And I know that 5%, 4%, 10% sounds like a small amount of patients. But if you think about this pie, and you can start taking away 5% here, 10% here, 5% here, you're really starting to get to this point where you can really start personalizing therapy for patients with metastatic colorectal cancer. So even if it's just 5%, that's a critical 5%. And if we can find effective treatments for this 5% here, this 10% here, this 5% here, maybe we get to the point where we can offer personalized treatments for a majority of our patients, and that's really exciting.
Yeah. I know we're running down on time, so I would like to remind everyone that if you have any more questions, feel free to leave them in the comments section. This video will be saved and shared on Facebook. Also, if you are looking for colorectal cancer support, please join us at the Colorectal Cancer Alliance's Facebook page, Blue Hope Nation. If you have any more questions, also feel free to reach out to me. My email is sestrada@ccalliance.org. I'd love to help, and thank you so much, Dr. Liu. I know you're very busy. We appreciate your
thanks
time.
for the invitation.
And thank you to the University of Colorado Hospital, a fantastic place. Thank you, and we will catch you next month.